Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today in the show, we have Alexandra Yakind. She is a neurointensivist, and she wrote the Kevin MD article, A PSA from a Neurologist to the Medical Community. Alexandra, welcome to the show.
Thank you so much for having me, Kevin.
We'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
Sure. So I'm currently a neurointensivist in Boston. I completed a neurocritical care fellowship, before that neurology residency. I'm from the New England area, and I'm really excited to be back.
So we don't have many neurointensivists on the show. So tell me exactly what that is and some of the typical cases that you would see.
That's a great question. Neurocritical care isn't super common, but it's a field in which specialty trained professionals, including physicians, advanced practice providers, nurses, work to take care of critically ill neurologic patients. So we take care of patients with large strokes, subarachnoid hemorrhages, neuromuscular disorders, basically anything neurologic that requires a patient to have an airway, so be intubated, or requires frequent neuro checks. Every comprehensive stroke center has to have a neuro ICU, so there are more and more of them as neurointerventional procedures are getting more common.
So walk us through one of your typical days, and I'm sure no day is really typical, but take us through a common day and some of the things that you would see.
Yeah, so our neuro ICU has about 10 to 15 patients a day. So I come in at 6 a.m. and I round with neurosurgery, and as well as our fellow and our residents. And we work really, really closely with neurosurgery because we see a lot of their post-operative cases too. And so it's a very collaborative environment in that sense. And then we have some sort of didactics, education, and then we round on the patients like you would in any other ICU, and more education following. And this kind of is different from some of the non-academic models that are out there, where sometimes you have more patient volume and less education, but it does vary. And unfortunately, we see really, really sick patients. So, patients who come in with some large brain bleeds, and a lot of our day has to do with talking to families about what this means. It's often, the worst day of their lives, something they couldn't imagine, and we have to walk them through what's going to happen from there on out.
So tell us about some of the rewards and challenges of being a neurointensivist.
There are two main things that I find rewarding. So it's a really team-based environment. So the nurses who take care of these patients are specially trained, and often they're the first eyes on the patient. They're the ones who are in the room all the time. So we rely heavily on them and their neuro exams to tell us what's going on with the patient minute to minute. And the second thing is this communication with families. It's challenging, but it's also really, really rewarding to be able to guide families through this in a way that, to the best of my ability, I can prevent secondary trauma that's associated with having family members in the ICU. So those are the things. And obviously, I'm a neurologist, I nerd out about localization and and all things brain. So that's another thing that I love about it.
So what are some of the challenges that you face?
They're the difficult cases, they stick with you, and I'm still learning how to incorporate that into my life and how to process that. One thing I was thinking about recently is how, we, especially when you work in critical care, you lose a lot of patients, but patients as in, people you take care of. And I remember in medical school, we had this tradition where we had anatomy lab and we honored the people who donated their bodies for it. But we don't really do that. We don't have any kind of ceremony surrounding the patients that we lose. And I've recently been thinking about how to incorporate that to be able to kind of process this really heart-wrenching experience sometimes.
All right, let's transition into the Kevin MD article that you wrote. It's titled, A PSA from a Neurologist to the Medical Community. Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
Sure. I've noticed over the years that people outside of neurology tend to call strokes CVAs, and people within neurology don't love it. And there's a disconnect. And I wanted to put us all on the same page. The main goal, overarching, was to draw awareness to stroke, and that for people who don't see it all the time, it has changed over the years. There are interventions and procedures that have taken this from a disease state that was with a dismal prognosis to something that can be cured and intervened upon. So that was the goal. Yeah.
So tell us why. Why don't neurologists like the term cerebrovascular accidents, CVAs?
Yeah, so CVA or cerebrovascular accident, neurologists don't like that term because strokes are not accidents. We know what causes them. And we know that there are risk factors, the same kind of risk factors you have for heart attacks. So high blood pressure, hyperlipidemia, diabetes. And yes, they happen suddenly, but they're certainly not accidents. And our whole job, and especially that of stroke neurologists, is to figure out what that cause is and to prevent it from happening in the future. So it kind of takes away from the science behind it.
So what should we be addressing these? Should we just call them hemorrhagic or ischemic strokes? So what's the right way that we should be addressing this condition? Because I have to admit, I'm guilty of calling strokes CVAs.
Yeah, no, that's a great question. And it something that came up in my mind after I wrote this was, where did the term stroke even come from? And there's not a lot written about it. What I found was that, it showed up in the Oxford Dictionary in like the 1500s, and it implied like palsy that happened by the stroke of God. So is that even the best word? Because it's something that isn't stemming from a scientific background. So at the same time, you have your International Stroke Association, you have a journal
Hmm.
called Stroke. So it's a term, despite its origins, has really taken on its own definition and its own life. So I think stroke is something that we can say that everyone will understand, but probably more accurate would be to say cerebral infarction or hemorrhage, because stroke encompasses both of those.
So what about transient ischemic attacks? Is that term okay from by neurologists?
Good question. It is, yeah. Yeah, it is. Although something to note is that sometimes you can have a clinical transient ischemic attack, but then actually have a stroke on your imaging, and at which case it becomes a stroke.
So I've heard some people refer to transient ischemic attacks as quote unquote mini strokes. What do you think about that?
This all gets into like the language and the weight of meaning that certain words carry, but it's not very accurate, because
Hmm.
like mini means small. So some
Hmm.
people, especially patients, might get confused. They might think I had a small stroke, but actually they had a TIA. So I think it's a little misinformative.
So you have an audience of clinicians here, a lot of them in primary care. What are some things about neurology or some messages other than this PSA that you want them to know about?
Just that, a lot of people are scared by neurology because they think it's a depressing field where patients don't do well. But that's really not the case anymore. Like, not just with stroke, but with MS and Parkinson's disease. Like, you probably have patients who you wouldn't know have these diseases because their symptoms are very well controlled. And so I would want primary care providers to know that we're a field that is really on the edge of research and trying to make lives of patients with these conditions better, and that there's a lot out there, and to keep learning, just like is my job in my field, and those, learning about primary care as well.
We're talking to Alexandra Yakind. She is a neurointensivist and she wrote the Kevin MD article, a PSA from a neurologist to the medical community. Alexandra, we also have a lot of medical students who listen to this show, and if they're interested in neurology or even pursuing neuro-intensive care, what are some character traits? What are some characteristics that they should have if they're eager to pursue this field?
There are lots of different kinds of people who go into neurology. Some people might not even know that there are like many subspecialties within neurology. So, there's neuroimmunology. So if you're interested at the of the intersection between your immune system and the brain and the central nervous system, that's one way that you could go. You could do neuroinfectious disease, you could do neuromuscular or intensive care or stroke, that are more inpatient types of specialties. I think something that's important to know for students is that the neurology exposure that you might get in medical school almost certainly doesn't represent the entire field. So if you happen to be placed in a cognitive neurology clinic and you only see patients with Alzheimer's disease, that's very different than what I do, for example. So if you have an interest in the brain and, in neuroscience, then explore your options. Talk to different subspecialists, to experts, about what the options are. And the other thing, just for trainees in general, is to think about not only what your interests are, but what your day-to-day life will be like. So I loved neuroscience in the brain when I was an undergrad, and knew that going into medical school, I would focus on one of those specialties. But then when I got to residency and I saw that most of the practice was clinic outpatient based, I thought, whoa, this isn't for me. Like, I love being in the hospital. I love the fast-paced environment. And then I found neurocritical care. So it's out there, and think about what you want your day-to-day life will be like, how you'll be fulfilled, and kind of find a way to combine that with your passion.
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
Yeah, so I think we talked about a lot of them, but my goal was to draw attention to stroke as a disease state that has changed drastically over the years. And that at the end of the day, no matter what we call things, we are all on the same page where, we're working towards the same goals of taking the best care of our patients. So we might as well keep learning from each other and how to make our care and our communication align.
Alexandra, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you.